morning again. This morning I'm going to be talking to you about work from our group at UVA, and I'm going to clarify and expand and talk more about two things that John mentioned right at the end of his talk. I don't have the pointer. Well, or you can run the slides. That would be okay as well. We're going to give the talk backwards. I needed a challenge. Okay, so I say on behalf of many, and I'm not kidding about that. I'll tell you more about that in just a second. On this slide are a couple of disclosures and a couple of advertisements. It's important for you to know that I'm the Chief Medical Officer of AMPT, which we talked about yesterday. Here is a society that I think is a lot of fun, and you might think is a lot of fun too. Here is a journal that I'm simply crazy about. Now, when I say on behalf of many, here's what I'm talking about. This is a list of people at UVA, essentially, that I work with all of the time. It's reasonably updated. These are people that I've spoken to or seen in the past month or so. The list has changed a lot as the years have gone by. Particularly important people, some of whom are with us today. Doug Lake is sitting out there. Doug is a mathematician. We've worked together since 2001. It's hard to think how any of this could have gotten done as well as it's been done without his input. Forrest Calland, you met yesterday, as a trauma surgeon, and has been intimately involved in clinical implementation and thinking about some of the monitoring that I'll be showing you as well. I'll be showing you results that were generated largely by Travis Moss. Travis is a cardiology fellow who's this week ending his research fellowship and beginning his clinical fellowship. He couldn't be with us today. He's rounding on heart failure patients at the hospital. As you'll see, we've done a lot of work in the neonatal ICU. Karen Fairchild and John Catwinkle have been the leading lights there as well. These are people that are at the faculty level. These, for the most part, are people that are at trainee level. I have only one international figure, and that's Manuela Ferrario from Milan. We're very actively working and publishing with her now. but her name is there to remind me that we do work internationally. We have, though, a great many domestic partners, for the most part academic medical centers, some that are not, and of course highlighted, although it's not in very big letters, is our very productive partnership of our group as part of the UVA MITRE partnership. So on a regular basis, Doug or I or somebody is in contact with people at all of these centers. Some of the centers here were represented in a large randomized trial that I'll tell you about as well. So even though we sit in Charlottesville, Virginia, which is a small place, we're at a good-sized university, and for years and years we've been very outward-facing to the rest of the nation and to whoever who's interested in the rest of the world toward developing analytics and towards sharing them and towards validating, and in short, just trying to change the world by using the information that we already have. Now, I would say that I would put our mission to you in this way. We concern ourselves with advanced medical analytics, and the definitions legitimately and reasonably might change among people, but today's definition for me is that when you're doing advanced medical analytics, you're adapting mathematics to a clinical context, and that requires an a priori knowledge of clinical pathophysiology and clinical medicine. And the result of doing medical analytics are numerical values that cannot be looked up in a chart. Now, that definition may change tomorrow. Others might have other points of view, but that's what Doug and I have been thinking about these days. Now, more specifically, as I say, our group intends to lead the world in developing and externally validating and testing predictive monitoring algorithms. And so the part of this, the overall mission that I'm going to be talking about right now, is the idea that apparently sudden critical illness can have subclinical, that is to say non-detectable prodromes with signatures of illness in the monitoring data, and that diagnosis and treatment at this early stage can save lives. And I'm going to give you several examples of this, but first let me take you quickly through a recipe that we try to stick to and have learned through the years. Step one, the hardest part, pick the right clinical problem. As you look around and see analytics being done in the field of healthcare, the first question that pops into my mind is, will the result of this help a patient? This can be a terribly difficult thing to sort out. What is a good question to ask and what is not a good question to ask? And of all the mathematics and computers and engineering that we do, the hardest thing that we do is trying to pick out the right things that we're going to work on. Now, as I say, I'm going to give you some examples. And so, for example, people get sick under our noses in the hospital. We want to work on that problem. The second thing that we prescribe is to look at the data yourself. So we found a signature for sepsis in premature infants that no one had ever thought about or talked about before. We found it because we got a lot of data and we started looking through the records ourselves and figuring out what baby got sick when, what did the heart rate time series look like then, a robust phenotype announced itself, and then we went forward from there. Other ways to go about doing this are to use existing frameworks and theories, and all of that is fine, but I'll tell you there was no existing heart rate analysis that was going to be useful in finding sepsis in premature infants. We adapted it once we saw what we had, what was there to see. Now, on the other side of the coin, when I look at what my clinician friends are doing, I sometimes think that the analysis could be deeper, that they've got the clinical part right and it all makes sense from that point of view, but the analysis gets limited because of fear of mathematics, and I overcame this fear a long time ago. I'm not any good at it, but I don't mind trying to drown in it. And Doug Lake, of course, has been, and other colleagues, I'll say Doug first and foremost, have been particularly useful in helping us do all of that. Now back to clinical matters again. Having come across an analytic that we think is going to be useful, we think it's terribly important to test it in clinical medicine. And so in this neonatal sepsis story, which I'll briefly touch on in a second, we ended up doing the largest randomized clinical trial ever undertaken in the field of neonatology for any reason in order to test the idea that our predictive monitoring might be able to help patients. And then finally, we think it's good to try to be useful to doctors and nurses and other clinicians at the bedside. And so we work hard on trying to develop displays that can be used intuitively without doctors having to recompute things in their mind as they go along. Now, I'm going to give 3 examples, and there's going to be a sidebar in the middle. And if I have time, and I'm talking fast, I'll show you a recent case from our hospital. So generally, here is the landscape that we work in: deteriorating patients requiring escalating care. And I'll be talking about patients that are already in an ICU that can develop complications, subacute, potentially catastrophic illness kinds of complications that might prolong their stay or lead them to die. We're also working on these problems, the problem of patients on hospital floors that get sick under our noses and require transfer to ICU, and patients that have recently been in ICUs and are thought to be getting better and go to a step-down unit that then bounce back again. And I'm not going to show you any results from any of that work today. I'm going to give you some examples from this side over here. Now, I've hinted at the idea that we have studied sepsis in the neonatal ICU. Sepsis is a particularly pernicious problem in premature infants. It affects 25% of them. The mortality rate is on the order of 20%. And those that survive often have impaired cognitive development and have special care needs for years and years into their life. The problem clinically is that you're looking at a baby that weighs a couple of pounds. There's no way to interact with that baby. Often the incubators are covered up for day-night confusion issues. And the question of whether or not a baby has this dire illness cannot really be resolved by standing at the bedside and looking at the baby. Now, the stakes are high with sepsis, and as a result of the dire consequences and the poor clinical detection, doctors and nurses are biased toward treating a lot of infants for sepsis that don't have sepsis. So at any given moment in our neonatal ICU, fully a third of the premature infants are receiving antibiotics for suspected or proven sepsis. Now, we got into this with the idea that we would be able to see something in the physiological monitoring that would show up before the dire signs had arrived, and lo and behold, we did. We found changes in the way that the heart rate time series looked. So this is an infant who became septic without ever becoming ill. And this is a 10-minute record of the heart rate. Babies' heart rates are faster than grown-ups' heart rates. And it tends to jump around a bit, and this is an age-old phenomenon called heart rate variability, and you're supposed to have it, is the bottom line. So here is an infant several hours before before sepsis was suspected, and at the time you can see easily that there's a difference between the two. I would characterize the difference to you as there being reduced variability at baseline, and then these decelerations or transient slowings of the heart rate. Now, the bradycardia or slow heart rate alarms go off around 100, so these would obviously never be alarmed upon. And if you just walked up and looked at what the heart rates were, you'd see a lot of the same numbers as normal. That is the fundamental discovery that we made 15 years ago and went forward to develop metrics around. So with those metrics that detect the degree to which this phenomenon was present, we did clinical studies and derived a heart rate characteristics index, now called the HERO score, and we started reporting that to clinicians. The units of this are the fold increase in risk that the baby will have clinical illness tomorrow. So it's truly anticipatory in that sense. So here is one-fold, that is the average risk of being septic in the next 24 hours. So if you're an infant, you want to be at that number or below. And this record that I'm showing you here took place about a week after we started displaying this to clinicians. We got FDA clearance and then started displaying it to clinicians. And the infant was doing fine. This is a 10-day record here. And so for days and days, the infant had been humming along at low risk of sepsis. And then the number went up, and it reached fully twofold the average risk. Now, the clinicians taking care of the infant knew about this monitor because we've been telling them about it. So they got interested and went over and looked at the baby. The baby looked fine. They drew the usual laboratory test. We could expound on that, but suffice it to say that they drew the laboratory test that one ordinarily draws when one suspects sepsis in the NICU. They were all normal. And they also drew a blood culture. And 12 hours later, the microbiology lab called up and said, your baby is growing gram-negative rods in his blood. Now, gram-negative sepsis in the neonatal ICU has a mortality that exceeds 50%. So I'm a cardiologist and take care of adults. The worst thing that can happen to you is a massive heart attack. The mortality rate from a massive heart attack is 40%. So neonatal sepsis is as dire an illness as I know to tell you about. So the clinicians put down the telephone, went back and looked at the infant. Infant still looked fine. Started antibiotics, and the baby never got sick. So never had a sign of clinical illness. So this is truly a remarkable and galvanizing clinical experience for all concerned. This kind of monitoring is now present in 2 or 3 dozen NICUs across the country and other places in the world. Anytime I talk to a clinician that uses this monitor, I hear that same story from them. Baby doing fine, score goes up, baby looks fine, blood culture positive, give antibiotics, nothing happens. A wonderful thing. And when I give talks to research groups, I say, I hope that the research that you're doing leads you to the kind of fulfillment and satisfaction that I get, and I dare say a lot of us have gotten from working on this particular project. Now, this has set the stage for everything that has followed. If we can do it in newborn infants, surely we can do it in everybody else. Doug and I had the epiphany a few years ago that we weren't going to die of neonatal sepsis, and we got busy with adults, but I'll come back to that in just a second. Now, the sidebar is that we had to adapt mathematics to what we were doing, because as I mentioned briefly before, no canonical heart rate variability measures detect the abnormality that I've just shown you. So actually, before Doug showed up, I worked with a young man, Joshua Richmond, and we got interested in entropy estimation to detect the change that I just showed you. and we devised something called sample entropy. Every line here is about a 3-hour discussion, and so I won't go into it. But just to give you the idea that we have had to take mathematics, either develop them or adapt them to what we do. You'll see Doug Lake's name here a lot. Josh Richmond did his PhD later on showing statistical properties of sample entropy. Doug and I did more on this. We've had the opportunity to work with John DeLoss, who's an atomic physicist at William & Mary, who got very interested in this and has worked a lot with us as well. Matthew Clark, you may have seen yesterday at the AMP demo. Suffice it to say that in addition to all the clinical things that we've done, there's been a good deal of mathematical work and engineering and computer work as well. Now, I mentioned a randomized trial. These are the results of that randomized trial. 3,000 infants who weighed 1,500 grams or less at 9 NICUs were randomized to either show the display that I showed you before or to not show that display. And there was no mandated intervention. We went to the 9 NICUs, we explained what the monitor was about, and then we turned them loose, and 5 years later came back and saw what had happened. And what had happened was that there was reduced mortality in the infants for whom the monitor was shown. Now, I'm doing something here that I detest for anyone else to do, and that is to distort the y-axis of the graph. Okay, and so you'll notice this picks up at probably at about 75% or so. The mortality rate in the 1,500 babies who had conventional monitoring only was 10.2% over the 120 days after we initiated the monitoring. Those for whom we showed the predictive monitoring, the mortality rate was 8.1%. What this translates into is we saved a baby for every 48 that we turned the monitor on for. And then if we look deeper into it, we pre-specified the group of extremely low birth weight infants less than 1 kilogram. For them, we only had to turn the monitor on for 23 in order to save a life. And not shown here is the fact that of the 25% of infants who actually got septic, we saved a life for every 12 infants who became septic during their NICU stay. As I say, galvanizing and highly motivating kinds of results. Now, we've not quit working in the NICU, and John mentioned a new kind of metric for early detection of illness that is more simple than what I've just shown you. And it centers on measuring of breathing in the neonatal ICU. So sepsis was an issue, and breathing, or rather lack of breathing, is an equally big issue in the NICU. And it comes in 2 flavors: apneas, where the babies just quit breathing, especially the kind of apneas that make the heart rate slow down and the oxygen level fall. Common event thought to signify illness clinically. Periodic breathing, or periodic apnea, depending on how you look at it, is usually shorter lived than these apneas and doesn't affect the heart rate and the oxygen level and is thought to be clinically benign. These concepts are based on extensive clinical experience. And are they correct? Well, to get the story started here, you have to be able to measure these kinds of things. These are measures developed by John DeLoss and all of us, but especially John and his students at William & Mary, towards accurately detecting apneas in periodic breathing. So this is what is shown on the clinical monitor. This is the heart rate up here. This is the oxygen level here. And this is the breathing. So this is as measured by movement of the chest. One of the contributions that John and his students made was to have an advanced filtering algorithm to get rid of noise and to cleanly identify the bits where the chest stops moving, to map them to a probability of apnea. Not shown here is the fact that there were hundreds of records like this jointly inspected by DeLoss and his co-workers and Karen Fairchild, John Catwinkle, and clinical neonatologists to validate the method involved here. But this is what we end up with an apnea record here. And then shown down here is later work from DeLoss and his group showing that this is in fact a short epoch of periodic breathing And I'll just say that the algorithms here involve time warping and wavelets, and it's very advanced and elegant and beautiful ways of doing things. But as a result of that, we can now quantify, and in fact we have, quantified apneas and periodic breathing in a very, very large number of premature infants. I'll show you results from more than 700. The most recent paper that we've sent in has more than 1,000. So this is one of the most interesting results. This is the result that I liked the best. I don't know that the neonatologists would admit that they didn't already know this. But what this shows is the natural history of these two disorders of breathing in premature infants. And what's shown here is a heat map of the number of apneas per day. The warmer the color, the more apneas per day, and a heat map of periodic breathing. And the more time spent in periodic breathing during the day, the warmer the color. And what we're showing is the results from 700 and some odd infants, and we have plotted the gestational age, that is to say the degree of prematurity at the time that they're born, as a function of time in the NICU, and we're measuring that actually as post-menstrual age, gestational age plus time in hospital. And what it shows, and even though this is consistent with clinical thinking, it's never been demonstrated in this kind of way, that apnea is an illness or a condition of the very premature over the first few weeks after they're born, after which it goes away. And it's not really a bother for infants that are born at later gestational ages. Periodic breathing, though, and there's a clear cutoff between them, is much more a disorder of infants that are born less premature and takes place a couple of or 3 weeks later on. A very vivid demonstration of the pathophysiology of breathing, the development of control of breathing in the premature human. Now, I'm not going to show you the rest of the story, which is to say, are apneas benign? Are apneas indicators of illness? And the answer is yes, sometimes. And the second question is periodic breathing always benign? And the answer is no, not always. So we've had one case that we know of sudden infant death syndrome in this large population that I've described. Doug found out that that infant had the most periodic breathing by far of any infant of the hundreds and hundreds that we have examined. That's another topic, and we'll let it rest right there. Now, what we're up to now is towards simpler ways to get this information. And John mentioned a cross-correlation measure, and what I'm showing you here are records of heart rate and oxygen level in 3 infants, and the mouse has come on, in whom there is a high cross-correlation, a high positive cross-correlation. That is to say, as the heart rate changes, the oxygen level changes in the same direction. And I've mentioned before that falling heart rate, falling oxygen level, this is a big deal in the NICU. So here's how so here are 3 records, and obviously what we're pointing out here is that these happen on different time scales. These records are all of the same length. Sometimes they go up and down together quickly. Sometimes they go down slowly and stay down for a long time, and sometimes there's just a slow drift of the 2 of them together. This is periodic breathing. Here's the chest movement down here in red. This is how periodic breathing, a malignant kind, leads to a high cross-correlation of those signals. This is how a long central apnea leads to a high cross-correlation of the signals, and this is the slow drift of somebody on a ventilator. Now, to measure this does not require EKG leads. You don't have to be in an ICU. All you need is a pulse oximetry device that will detect both the heart rate and the oxygen level. This is something that can be put on the finger of an adult, on the ear or the foot of a premature infant, and would lend itself much better than what I was showing you before to at-home monitoring or monitoring of large numbers of people or more austere or resource-limited environments. It works awfully well. This is from Doug and from Karen Fairchild. This is a group of infants, 165 of them, that had sepsis or a related illness, necrotizing enterocolitis. And this is the change in the cross-correlation value itself. There's no modeling here. This is just a metric derived from those 2 time series. and showing that it rises over the day or so prior to the clinical diagnosis of illness. For comparison, this is how the HERO score goes up prior to illness in a very, very large data set, and they are of a muchness. Now, there's more work to be done to tie all of this down, but that's where we are towards more simplified monitoring of infants. And so last but not least, let me tell you about the work in adults. We sought signatures of illness in adult ICU patients, not just for sepsis, but for two other illnesses where we thought that early detection might lead to early intervention and improved therapies: respiratory failure and hemorrhage. We studied a very, very large data set, 150 patient years of data from more than 9,000 ICU patients. This is actually adults plus infants, but 8,500 of these patients were adults. For sure, these events have high impact. Here we are: surgical ICU, medical ICU, intubation, lung failure, sepsis, hemorrhage. These are the rates. These work out to 1 or 2 events per UVA ICU per week. Not rare. Not every day, but not rare. And this is the impact on length of stay, a several-fold increase for each of these conditions in ICU length of stay. And this is the impact on mortality, a several-fold increase in the mortality rate for these events. Now, Travis Moss principally did an enormous amount of work toward understanding whether or not there were signatures of illness that would be carried through from one ICU to the next and might be the foundation for universal monitoring strategies that could be used anywhere. And what's shown in this plot are the log odds plots from logistic regression. The regression involved a couple of dozen, for the most part, extracted or measured parameters from the physiological monitoring. If the tiles here are yellow, that means that the measured parameter rose as the rising value of the parameter meant increasing risk. And as an example here, we've pulled out this one from here. Intubation in the surgical ICU is heralded by rising respiratory rate. Here are the units of respiratory rate right here. If the tile is blue, it's the opposite. A fall in the measured parameter means increasing risk of imminent event. And as an example, we've pulled this one out. This is blood pressure in the surgical ICU prior to hemorrhage, falling blood pressure, increasing risk of hemorrhage. We didn't tell the computer that. It came out with that, and it was just reassuring to us to see that the clinical truth was captured. But there are a lot of other things that we don't know to look at when we look at patients. So in addition to the canonical vital signs, heart rate, respiratory rate, oxygen saturation, blood pressure, this is the variability of one of the metrics. This is the cross-correlation of one of the metrics. This is, in fact, the cross-correlation of that I just showed you. Heart rate and oxygen saturation, as you can see, a rising value portends any illness in the NICU. So the major findings in adults are that indeed respiratory failure signs itself the same way in the surgical MICU and the medical ICU, rising values of some parameters, falling values of others. Likewise, hemorrhage signs itself in the same way, rising heart rate in addition to falling blood pressure and some other things. To our surprise, and very interestingly, sepsis is more variable between the two units. And if you stop and think about it, it shouldn't make bad sense that the postoperative patients getting septic might have some sort of difference in their illness presentation, physiology, and etiology compared to patients in a medical ICU. So, and as I said before, when babies get sick, they always do so in the same way, and in a way that really doesn't capitulate any of the adult illnesses. So from this set of experimental work, every column represents a multivariable logistic regression model that can be used in future work for early detection of patients with illness. In our hands, we saw that the models changed in value as the events approached. So we took all of the events of intubation, lined them up at time 0, watched the outputs of these regression models change, and sure enough, over the 12 or 24 hours or so, there's a dynamical change, an increase in the predicted risk as the event got close. Here is intubation, here is hemorrhage. Here is sepsis. Now you look at this and you think, well, it doesn't look like it went up so terribly much, but I'll tell you that the magnitude of the increase in the risk estimate for sepsis in the adult ICUs is the same as it is in the neonatal ICU. And as I've already told you, that degree of change can be parlayed by clinicians into improved care of the patients such that their outcome improves. There are a few things coming up in the future that I've hinted at. We're very close to having these kinds of models for floor patients who are about to be transferred to ICUs. Another data set of more than 8,000 patients, separate patients, but an equally sized data set. We're interested in this idea of using the results I've already shown you and monitoring other patients, ICU graduates who are now on a step-down unit at risk of bouncing back. The preliminary look at that is very favorable indeed. A project that is very dear to Forrest's heart. If you never have high risk in the ICU, do you live happily ever after? We will figure that out. Simpler NICU monitoring using pulse oximetry only, I've already described that. And then something that we're just starting to get our teeth in, and this is something of particular interest for the partnership with MITRE, and that is Rick Shannon's concept of hovering monitoring in patients, especially in austere environments. Well, that's everything that I brought along to show you. I'd be happy to talk offline about everything. The next step for our group in general is to work with people outside of the University of Virginia, across the country, around the world, to share these analytics and the goal number one, be sure that they work elsewhere. These are large numbers of patients, but this is one hospital. And if they do work, then to get them out there. Our lives changed when we figured out that we were saving babies. We intend to do that for everybody else as well. Thank you.